Hello, class. I'm going to be teaching today on assessment for post-traumatic stress disorder and trauma treatment. So I'd like you all to review the DSM-5 criteria for PTSD that we have gone over prior before listening to this lecture, because that will give you a good set of criteria to keep in mind when we're going through the idea of assessment. So let's get started, and you can follow along on the PowerPoint that I have sent you. And we're going to start with the triphasic model of treatment. Now, this is a model that's very common in trauma treatment, and it's something that I personally use with my own clients, not just trauma actually. I like to use this model for many different mental health diagnoses because I think that it gives a really good overall framework in terms of the progression of therapy. So let's look at the triphasic model. The first phase is safety and stabilization, and we'll go through these in detail in a moment. The second phase is trauma memory processing, or if you're dealing with another mental health disorder, this would be more direct interventions to whatever mental health issue you're treating. And then the final phase, phase 3, is reconnection. So let's go into these different phases in a bit more detail. So this first phase of safety and stabilization is so important. Whenever you're treating trauma, you always want to go safety and stabilization before ever doing any trauma memory processing. So I am not a big fan of on the ground trauma memory work without something done within the context of a therapeutic relationship and also having worked through phase 1. Now, the phase 1, 2, and 3 are not necessarily sequential, like you finish phase 1, then go on to phase 2, then phase 3, because you often do have to go back to phase 1 while doing trauma memory work. So you might have moved well through phase 1, and then in the midst of doing art therapy or EMDR or narrative or one of the phase 2 interventions, the client may need some more work on coping skills and emotional regulation as things get more difficult in treatment. So then you would go back to phase 1. And so you might jump around. So you never skip phase 1, but you may go back to it. You may go all the way to phase 3 and still have to go back and do some safety and stabilization of phase 1. The therapeutic alliance is one of the most important components of any mental health treatment, as we know. So really establishing that rapport, establishing the fact that that the relationship and also the counseling room is a safe place for the client, that you are a safe person, that you will maintain confidentiality, a non-judgmental attitude, not project your own values onto the client, and letting the client know that whatever they need to share that you can handle. So also managing your own countertransference and that type of thing. So going through the assessment, which we are going to get into more detail in a moment, involves both the clinical interview and sometimes will involve some additional assessment tools. I like to use ones such as Beck Depression Inventory, Beck Anxiety Inventory. I have some for patients with OCD, and just various symptom assessments in addition to some suicidal assessments and that type of thing can be very helpful in phase 1. And also throughout treatment in terms of noting progress. Another aspect of phase 1 is resolving current dangers, such as victimizing relationships, suicidality, homicidality, self-harm, substance abuse, and other addictions that could interfere with treatment. Now, there is a lot of debate in terms of if there is an addiction present, do you treat the addiction first? Do you treat the trauma first? Do you treat them concurrently? And for me, that's really done on a case-by-case basis and assessing the client as a whole. But if somebody is in active substance abuse, I probably will not move into phase 2 trauma memory work until that's had treatment. So again, for the assessment, we're going to look at biopsychosocial spiritual issues and do a really good mental status examination, background. We're going to look at support systems that have been in place, evaluate previous treatment, what has worked, what has not worked. Are they currently on any medications? If not, do they need a med eval? What is their symptom level? So, for example, if I give them an assessment for depression and they're scoring severe, I'm going to do work with the depression first before moving into any trauma memory work, so that those symptoms can hopefully come down. Now, again, sometimes the symptoms are not going to decrease until you've actually been able to process some of those trauma memories fully. But we do want them to come out of that severe range, because emotional regulation is very important. And one of the main criteria for working through phase one is the client's ability to maintain some emotional regulation. We do this by teaching SUDS levels, which is standard units of distress on the 0 to 10 scale. And so if I have clients all the way up at a 10, in phase one, we're going to do a lot of work on getting those SUDS numbers back down within more moderate range before moving on to phase two. I'm also going to teach the client how to do their own self-regulation. So if they're out of the office and they feel their SUDS numbers going up to a 7 or 8, how do they on their own work them back down to a 4 or 5 or something like that? We're also going to evaluate reality testing and dissociation. So how present are the clients in terms of ability to recognize current safety, as opposed to being stuck in past flashbacks and that type of thing. So we'll do the whole DSM-5 assessment and look at intrusive thoughts, hypervigilance, negative cognitions and moods, and avoidance. But we're gonna do a broader assessment as well, and include more dissociation testing, if they have any memory loss, memory gaps, if there are multiple personalities or alters, and do they have amnesia between parts? And so these are all things that we're going to assess for in phase one, and build that therapeutic alliance and get to know the client more and help the client to get to know us more. Now, this phase one can last a few sessions. It can last several months. It can last several years. And I've even had one or two clients where we have not moved past phase one if they are unable to do that. So I stay in phase one as long as the client needs, and I'm very careful not to move on to phase two too quickly. Now, there are some clients that come in, maybe they've had a lot of past counseling before and their SUDS levels remain low, their ability to emotionally regulate is very good, their symptom levels are manageable, and within a few sessions they are ready to move on to phase two. So again, this is going to be really on a case-by-case basis how long you remain in this phase before starting trauma memory work. So again, in assessment, we're going to be looking at temperament and personality. We're going to be looking within the cultural context of the client, because that's going to be very important when we go to do some of these assessments. We want to understand that within their own cultural context, within their own religious context, within their own belief system. We're going to look at attachment issues. And this is very important, especially for those that have been victims of trauma at the hands of caregivers. So we do want to assess attachment as well, and also their current social network and ability to maintain connections currently. And as I said, affect regulation and their mood. Dissociation. We want to look at their symptoms. How frequent are they? How intense are they? How long do they last? What type of cycles do they come in? And then again, we're going to look to our DSM, and in terms of diagnosis, we really want to look at the driving force behind the symptoms. So for somebody that again has multiple traumatic incidents during childhood, I am going to evaluate them for not only a major depressive disorder if they present with depressive symptoms, but also for post-traumatic stress disorder or something like that. There's all different assessment instruments that you can use in terms of assisting in that clinical interview. Now, some assessments are for public use and they are free of charge. Others will be commercial and there'll be a fee associated with them. With any assessment, you are going to want to get some training on them, and some will require actually advanced professional training. So you can do that by attending seminars and workshops put on for that specific assessment. You can seek supervision and consultation for other professionals that are using those assessments. You can read and do research and that type of thing to learn more about when the assessments have been used and how effective they've been. So just keep in mind that there are many different types of assessments out there, but you do want to gain competency before using any of them. So some examples of the public instruments would be, as I mentioned, Beck Anxiety and Depression Inventory. I really like these because they're quick, they're easily administered, and they seem to be very accurate in terms of levels of anxiety and depression. There's a post-traumatic stress disorder checklist that goes along with DSM-5. There's an impact of event scale. And this is great to be able to get a broader picture of the different events that have occurred in their life and from the client's perspective, how impactful they have been. The ego resiliency scale I really like. This is measuring ego strength. And this is going to be important when you're going into phase 2 as the client can deal with some difficulty as those painful memories come up. Really assessing their ego strength throughout treatment is important. There's also projective assessments such as the house tree person, which I love for trauma treatment, and sentence completion is another one. But I have found great success with house tree person in terms of giving me clinical information for assessment and also raising the client's self-awareness, and then at the end of treatment being able to visually see progress with art therapy has been wonderful. There's also some dissociative scales such as dissociative experience scale that can be very helpful. So as I talked about the SUD scale, the standard units of distress, this is something that I have in my office. I laminated a picture that has a smiley face at 0 and a frown face at 10, and then a continuum in between to help clients visualize. And we do a lot of work saying, you know, what does a 7 look like for you? What does a 2 look like for you? Some people are never going to get to a 0, and so we individualize those SUD scales when we're working through phase 1 for each client. Grounding is another really important skill to attain in phase 1. So grounding is the ability to maintain awareness of present safety. We do this through relaxation exercises, and as those SUDS numbers increase, the ability to return to the here and now as soon as possible. So as those trauma memories come, we want to be able to have dual attention for the client, being able to attend to the memories to adequately reprocess them, but also attend to their current safety. We do this through imagery, deep breathing, muscle relaxation, positive self-talk. And there's a lot of different grounding exercises that are very effective. Specifically, my absolute favorite one, especially when I'm doing some pretty heavy trauma memory work, is to toss a pillow back and forth with a client. I use a pillow because they tend to sometimes throw it too hard at me just because they may feel somewhat dissociated. But the tossing and catching a pillow for whatever reason, it's extremely grounding. I guess it has to do with the brain having to assess depth regulation and those type of things. But that's been, to me, the most effective. Sometimes splashing some cold water on their face, having to look around the room and name specific things that are in our counseling office, putting their feet on the ground and feeling the floor below them is another one. Nature is extremely grounding, so going outside and just looking at the steadiness of the trees and the sky and the grass, that can be very helpful too. But my favorite one is the tossing the pillow. And also use a little humor while I'm tossing the pillow and just joke about how uncoordinated I am and that type of thing. And that really does help seem to bring them kind of back into the here and now. And then finally, containment. So this is pacing our work, being able to contain the emotions and contain the exposure so that they're not just overexposed and flooded once we start phase 2. So we call it titrating. So if you think of a faucet, being able to turn it on just a little bit so that it's drip, 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 as opposed to just cranking the faucet and having the water flood out. So that's called titrating, and I do teach the clients about this in phase 1, and so that helps with containment. Also, some other coping skills, doing a self-care box so that they can open the lid to do their grief work, their trauma processing, but they can also close the lid and put it away for a while. Journaling is very important. Also, that box can include a hope box with helpful memories and scriptures or whatever the client would like to use. Massage, exercise, all various coping skills that are effective in the containment. They may need to do some additional containment exercises such as thought stopping, or there's one with a brake accelerator that they can visualize. So putting their foot on the brake when they need to take a break from our trauma processing, and then on the gas when we're going to kind of open up those memories a bit more. And you can help them visualize this as well with their box. You can help them visualize a padlock on it. With the faucet, you can help them visualize a lock on that faucet so it can't open times when they don't want to open it. So imagery can be very effective. Okay, so once you are very comfortable with the client's ability to emotionally regulate, once you've resolved current dangers, if they need meds, once that's been established through a doctor, once you feel very comfortable that they are going to be safe, cranking up the heat a little bit in phase 2, then you move on to trauma memory processing. What I want students to remember is that even though we're very focused on techniques and interventions, one of the most powerful components of phase 2 is the counselor bearing witness to the experience of the client. So for many clients, this might be the first time that they've ever shared the traumatic experience with anyone in the world. Or they may have shared it before and people have minimized or dismissed their experiences and their pain. So it's very important that we recognize the amazing healing power of being able to bear witness and just sit in the dark place with the client and provide empathy and a non-judgmental ear and appear very comfortable with our ability to remain present with them. So in addition to bearing witness, there are several different interventions that are very helpful in phase 2. And these are going to go along with whatever theory you choose to work with the client. So for example, if you're using narrative therapy, there are many narrative interventions such as verbally sharing the story as in regular talk therapy, doing a timeline, or this is one of my favorite, doing an autobiography where you work with the client in a progressive way. So you would say, if you were going to write an autobiography, what would the title be? And so for homework, they might have to come up with the title. And then the next time they may have to say, okay, I want you to divide this into chapters in terms of time chunks. And you can do it in any way you want. But do that. Tell me, maybe you would pick from 0 to 4 as the first chapter, and then from age 5, it would have its own chapter. So getting them to break it into different time chunks for the book, and then labeling those chapters and giving a title. And then you can move through with just, okay, give me bare bones of what would be included in this chapter, just bullet points. And then they can fill that in more and more, greater detail, add illustrations. And that's just an amazing way for people to use narrative therapy in terms of trauma memory processing. There's also written accounts of the trauma and letter of impact. That's another great intervention to have them draft a letter maybe to their perpetrator that they're not going to send, but writing out the what the impact of that trauma had on their own life. So, for example, they might write a letter of impact to the to Al Qaeda or the people that that were behind 9/11, and write out the impact that it had on their own life, and then tear up the letter, burn it, whatever they want to do. If you're coming from a CBT approach, cognitive behavioral therapy, you can work in this phase 2 on confronting cognitive distortions and cognitive restructuring. There's distortions often about self and others and the world around them, which we'll talk about with world assumptions theory. And so doing some of that cognitive restructuring, working on shame, and building up a positive self-image. Art therapy is extremely effective because it accesses right brain material. So I like to include some art therapy when we're doing trauma memory processing in addition to the talk therapy. Reconnecting with emotions such as anger, sadness, disappointment, that type of thing. EMDR, eye movement desensitization reprocessing, is another really effective tool. Now, you do need an additional certification to do EMDR, but it's something that I use quite frequently in counseling, and it's wonderful to access right brain material and help reprocess those memories, and kind of reduce the emotional charge and help them move into long-term memory, which we'll go over more. Assertiveness training, other skills training, social skills, boundary training, those can all be very effective in phase 2 in helping improve quality of life. Okay, and then finally, phase 3 is reconnection. So this is redefining oneself in meaningful relationships and life activities. Again, this is after they've moved through phase 2 and back and forth possibly, then coming towards the end of therapy, preparing for termination, preparing for life after counseling. Sometimes doing exercises such as a celebration of their progress, doing some type of memorial, doing some grief work sometimes is necessary in phase 3. There's grief and loss in terminating the counseling relationship, so that may trigger some other grief and loss. There's also grief and loss once they've worked through phase 2 and the post-traumatic stress symptoms have decreased. Then there's also this grief that can often come up for all the time lost. So, if those traumas wouldn't have happened, my 20s and my 30s would have been so different. And so allowing the client that mourning time is very important. Doing a letter to self and talking about how proud they are for doing the really difficult work. Moving from victim mentality to survivor identity is a wonderful thing to do in phase 3. And then again, preparing for termination, reflecting on the counseling process, future goals, what happens after they terminate. Are there groups maybe that will help them, referrals if necessary, and community resources, or contacting you again in the future. So that is something that I really like to take phase 3 as a time for me to reflect back all the strengths that I see in them, to reassure them that what they went through was incredibly difficult and that they showed a lot of courage and bravery for working through all that they did, and acknowledging the the pain that can be a part of therapy, specifically in phase two. So being able to reflect back on that. So that is a brief over overview of the triphasic model. And for you all at this point in the semester, I want you to focus mostly on phase one assessment, but I think it's good to have a big picture as well as we move further along then into treatment and interventions and that type of thing. So feel free to ask me any questions, and when we meet in live class together, we can go over anything in addition you'd like to as well. Or if you'd like an individual meeting to go through any of this, please let me know. So you all be blessed, and I look forward to seeing you in class.